Good afternoon, and thank you for joining us for this special seminar, the 9th Annual Brett Tindall Memorial Lecture. I'd like to start by acknowledging the Darwal people, who are the traditional custodians of the land from which I join you today, and acknowledge the traditional owners of the lands on which we all gather today, and pay my respects to elders past, present and emerging. And I extend that respect to any Aboriginal and Torres Strait Islander peoples who join us today. Before we get started, I'd just like to get across some housekeeping issues, particularly those who are not used to using this Teams system. So we really encourage questions, and the format of today will be that there will be a seminar, a lecture from Nittaya, followed by a panel discussion and Q&A. And so we invite you to interact and ask questions by putting writing questions into the Q&A chat screen, which is the icon with the question mark in the middle of it. If you click on that, you can write your questions. Please identify yourself. And once you will be able to see the questions that other people are asking, and you can upvote those or support those that you think are most interesting. And I encourage you to engage that way, both in terms of asking questions of Nittaya and of the panelists. So I'd just like to give an introduction around Brett Tindall, to whom this seminar is dedicated. So Brett was born in 1961, and he completed his first degree at Cumberland College of Health Sciences, and then spent 4 years of an undergraduate degree at the medical school in Newcastle in Australia. But he didn't complete his medical degree because this was the early 80s and he saw the oncoming AIDS epidemic around him. He moved to Sydney and was quickly appointed as a research assistant to David Cooper, who was then the director of the National Centre of HIV Epidemiology and Clinical Research, or NCHECA, which latterly became the Kirby. Brett was one of the first employees of NCHECA, and he played a critical, multi-skilled role in those early days. He was quickly promoted from research assistant to senior project scientist and took on a range of high-level administrative responsibilities as well as scientific responsibilities. Brett was the key to NCHECA's success in the initiation of many of the early pivotal clinical studies and initiatives that were led by David Cooper. As Garrett Prestige, who's still at the Kirby, has said of that time, Brett helped clinicians understand how best to work with the community, to get services operating and to start the research response that was so needed. That approach of attempting to work in partnership with community was what has helped the Australian response to HIV and to other infectious diseases and bloodborne viruses be so successful. And that philosophy that Brett brought to the early days of NCHECA has permeated the philosophy and aspiration of the way that the Kirby still wants to do its research going forward. Excuse me. Brett was passionately involved in developing the scientific and community responses at both national and international levels. Notably, he was a committee member of ACON, the AIDS Council of New South Wales, from the very earliest days. And from that capacity, his expertise and dynamism were recognised by Dr. Jonathan Mann, who is then the director of the Global Program on AIDS. And through that association, Brett was actively recruited and involved in various WHO meetings in the late 80s and early 90s that were pivotal for the global management of HIV/AIDS. In 1991 and in 1992, Brett was appointed as a consultant to governments of the Western Pacific region to assist in the establishment of HIV surveillance and policy initiatives. And it was through this involvement with WHO that he met the Kirby's patron, the Honourable Michael Kirby. When Brett learned of his HIV status, he had already commenced his work in the field, but his diagnosis drove even a stronger passion to make a difference. Brett's work scientifically was second to none. Brett made seminal contributions both in the clinic and in the laboratory to a number of pivotal studies that describe the natural history of HIV. He was pivotal in the studies that made the first description of the seroconversion illness or primary HIV illness, which was then published in The Lancet, and was also pivotal in making the observation that there was a cohort of long-term non-progressors among the people infected from blood donations in Sydney, called the Sydney Blood Bank cohort, and that was later put down to a NEF-deleted virus. Brett's ability to work across the community, the clinic, and the laboratory is again underpins the philosophy of the remit of the Kirby to this day. Brett achieved an MSc through the University of New South Wales, and his thesis was entitled Factors Associated with Human Immunodeficiency Virus Infection and the Development of the Acquired Immunodeficiency Syndrome. And his PhD was awarded in 1993. However, he passed away in 1994 at just aged 33. Despite his short life, he made an immense and lasting impact. When I started my PhD in the laboratory at or around about that time, Brett was already unwell and not a presence in person, but his presence pervaded the lab, and the senior scientists in the lab at that stage would always describe what Brett would have done in that situation. So Brett's legacy lives on, not only through his work, but through the indelible impact he has made as a friend to many here at the Kirby, and in setting the agenda and the underpinning approach and philosophy of the Kirby to research. This annual lecture is our way of commemorating Brett and his achievements. The inaugural lecture was given in 2012 by Dr. Frits van Gresven, and last year's was given by Dr. Kerry Chant, who we all know now as the prominent leader of the response in New South Wales against COVID-19. Today, we host one of our region's most eminent and effective researchers, Dr. Nittaya Phanuphak. Nittaya is an extraordinary individual and has recently been appointed as the Executive Director of the newly formed Institute of HIV Research and Innovation in Bangkok, Thailand. She has a deep interest in HIV prevention and treatment in key populations, and especially around the use of key population-led health service research and approaches to enhance the access to HIV testing, prevention and treatment among men who have sex with men and transgender women. She conducts community-based implementation research and currently works actively with community and government partners to establish national technical assistance platforms and to support the accreditation and legalisation of key population lay providers, and importantly, to develop pathways to sustainability of these health services through local domestic funding in Thailand. In 2015, she supported and was integral to the establishment of the Tangerine Community Health Centre on the Chulalongkorn Health Precinct in Bangkok. This centre offers an integrated hormone therapy and sexual health service. The Tangerine Community Health Centre has provided services to almost 3,000 transgender women and transgender men over the last 3 years. The model is very effective and is currently being expanded to community-based organisations working with transgender people throughout the region. I'll hand over to Nittaya to make a presentation. Welcome, Nittaya.
Thank you very much, Tony, for that very impressive introduction. I hope you all can hear me well. And it is my great honor and great pleasure to be able to deliver this year Brett Tindall Memorial Lecture. After my father, who did this lecture a few years ago and who just retired after working in the HIV/AIDS field for 35 years. So it's truly my great pleasure, my great happiness to be here with all of you today. And the title of the talk today is Give the Community the Tools and Devil and AIDS in Thailand. And before we start, I actually would like all of you to confirm with yourself if you really want to end AIDS. Because I'm asking this because I don't think that everyone, even working in the HIV/AIDS field, would want to end AIDS. If AIDS not yet ended equals money not stop coming in to you, even if you are doing business as usual. But if you really want to end AIDS, we need serious community engagement. And today we will talk about why we need serious community engagement and how its impact, its sustainability, as well as its adaptability to other health conditions. And Thailand, very similar to many other countries in the region, has seen a growing proportions of new infections, new HIV infections coming in from key populations, especially men who have sex with men and transgender women. And we know that the HIV prevention package coverage, as defined very conventionally here as distribution of condoms and lubricants and counseling and STI screening, has been very low among key populations, no more than 75%. And we also know that this conventional package of HIV prevention is not enough to end AIDS. And now we also know that if we would like to aim for ending AIDS, we may want to follow the status neutral approach to HIV. This is to shift the paradigm of how we do HIV prevention and HIV treatment program in order to end AIDS. And in this status neutral approach, once a person come into the system with HIV testing as an entry point, we will need to actively engage that person regardless of the HIV status in order to achieve the final common goal of negligible risk of either transmitting HIV or acquiring HIV through the U equals U or through PrEP. We now have the tools to end AIDS, but we may not be doing good enough to put the tools in the right hands. And we can see that especially among key populations, those tools may not be easily accessible to them or may not be widely available. Or even if it's available, the clinic settings where these tools are available may have staff with judgmental attitudes, or may have staff who were not, do not have their capacity being updated or being trained, qualified. So in 2015, we have this key population-led health services concept established. And this is actually because of the work that we have been doing with our community-based organization or CBO partners during that time, in a way that we use the community-based model for the work. And many of you here may be very familiar that this community-based model is very common back then. And within this community-based model, the CBO would reach and recruit their friends and wait in the community for us in the hospital, in their clinic, to move out to them to provide HIV testing. And that could happen every week, every 2 weeks, or every month. And after a while, all of us feel exhausted. And the CBOs learned that many of their friends couldn't wait that long to get HIV testing, even though they really wanted to get HIV testing. So a few leaders of these CBOs we worked with came to us and asked whether we could teach them to collect blood samples and to do HIV testing by themselves. And we said, yes, let's do that together. And then KPLHS started. So under this KPLHS, the communities of key populations are the one who design how the set of HIV-related health services should be. So this set of health services could be different from one community to another community, but we can ensure that all the services are needs-based, demand-driven, and client-centered. And these CBOs and their layer providers are not only the one who design the service, but they are the one who also co-delivering the service as well. And our role is to train them and make them qualified to provide this service at high quality. And there are so many service points that key population or KP layer providers can have their unique roles in this reach, recruit, test, treat, prevent, and retain cascade. This is a cascade that Thailand used to plan its national ending AIDS strategy. And we will not go through all these service points, but I just would like to highlight two key examples, the same-day PrEP and the gender-affirming services for transgender women here today. And for the same-day PrEP service, this is actually what is initiated by our CBO colleagues after they have experienced a few friends who seroconverted while waiting to come back to learn their laboratory results and having PrEP prescribed, even though they already came in for HIV testing. So within this flow, you can see that once the client coming into the CBO clinics, they will have their blood draw, and HIV testing will be done by KP lab providers on site, which means within the CBO clinics, using the rapid test assay. And the rest of blood samples will be sent to outsourced lab for creatinine and hepatitis serology. And within half an hour that we get the HIV test results, the test results will be shared with a doctor via the online chat application. So that the doctor in the affiliated or supporting hospital can review the test results and then approves the prescription of PrEP, so that the one bottle of PrEP can be given out to the clients by the KP lab providers within that same hour. And you can see here that we do not always wait to get the creatinine and hepatitis serology test results back before we have the first bottle be given to the client. And the creatinine and hepatitis test results may come back later on that day or a few days later. And then we will use the same online chat application to share those test results with the doctors and then to get any further recommendations as needed. And our CBO colleagues are using this same-day PrEP flow, not only for PrEP initiation visits, but also for PrEP follow-up visits as well. And the uptake of PrEP through this key population-led PrEP service has been going so well to the level that a few infectious disease doctors in our country started to urge the National Health Security Office, or NHSO, who is the payer of health services in our country, to allow the CBO to directly reimburse the per service cost for the PrEP service that they are providing in the same way that the hospital will do if the hospital is providing PrEP service to the clients. And the direct financing mechanism to the CBOs is very crucial for PrEP implementation in the country. Although this was proposed to NHSO by only a few infectious disease doctors who contributes to a very small minority of the overall infectious disease doctors in the country. But we know it is crucial because right now the KP-led PrEP service contributed to almost 60% of overall PrEP uptake in the country. And although we have PrEP included under the universal health coverage in Thailand since October last year, the uptake has not been very good. It has been very slow because the effort may be wrongly made to try to expand PrEP through public health hospitals. Now let's shift to the gender affirming care for transgender clients. And this concept also started in 2015. And this National Transgender Community Consultation in Thailand was one of the key activities which lead to the success of this transgender healthcare establishment in the country. And the Tangerine Clinic that Tony already mentioned during the introduction is actually formed as a result of that national transgender community consultation in order to demonstrate the integrative model of having gender affirming care and sexual health care be together in one setting. And the Tangerine Clinic has been very successful to demonstrate the otherwise invisible number of transgender women and transgender men who are so in need of quality health care. And over the past few years, Tangerine Clinic has served almost 4,000 transgender clients and have demonstrated high HIV positive testing yield at 10% among transgender women. Although you can see here that the proportion of PrEP uptake has not been very high. And the model, the integrative model of sexual health together with gender affirming care has been expanded to other 7 community-based organizations in the country. And we now have around 40 trans lay providers who have been able to provide more than 11,000 HIV testing and almost 700 PrEP services to their transgender women clients. But if you look at the proportion of transgender women who are using PrEP under the key population-led PrEP program in the country right now, you can see that they still contribute to a very small proportion of the overall PrEP users, only 14%, as compared to the almost 85% among MSM. And this is disproportionate to the estimated population size of transgender women and MSM in Thailand, which we know that we should have around 300,000 transgender women and 500,000 MSM. So you can see that the proportion of transgender women receiving PrEP here is much lower than the proportion of MSM. So to explore further, last year we did a small survey among transgender women in Bangkok, and we can see here that only 40% of transgender women in Bangkok were aware of PrEP, and only 7% of them were actually using PrEP at that time. So this has led to the creation of the PrEP in the City campaign. The PrEP in the City campaign is the first PrEP campaign for transgender women in Asia that was designed, produced, and delivered by transgender women. And the campaign portrays the daily lives of ordinary transgender women who integrate PrEP use into their routines. And we also use the gain framing messages to highlight PrEP use rather than the use of risk reduction messages that may not be proved successful in the past for other populations. And the campaign also aimed to enhance the visibility of transgender women in Thai healthcare system. The campaign was actually just launched last week, Wednesday last week, in 20 BTS stations or the SkyTrain stations in Bangkok, as well as on the a few large LED screens in Bangkok, such as the one at the Asok intersection shown here in this slide. And also on bus wrap. This one is just in front of Lumpini Park across our office, as well as through the online social media. And we realized that this is just the awareness creation phase of the campaign, and we will need to do many more works to ensure that the awareness will translate into actual consideration and finally the use of PrEP among transgender women in the country. But we feel that this campaign is so much needed, is crucial, and we have started to see a few positive responses coming in through inboxes asking what actually PrEP is and where they can get more information or where they can get more counseling or consultation for PrEP services. So now, after 5 years of KP-LHS implementation, we have demonstrated that KP-LHS is feasible and is very effective in getting to key populations who are at very high risk of acquiring HIV. The KP-led providers under this KP-LHS program has also contributed to more than half of HIV testing, more than 1/3 of HIV diagnosis, and more than half of PrEP services among MSM and transgender women in Thailand over the past few years. And we use these data to advocate for the institutionalization of KP-LHS training and certification processes, which also lead to the legalization of medical services or clinical services performed by KP-led providers. And finally, it has led to the pilot phase of the domestic financing mechanism, where the CBOs will get direct reimbursement from the government for the services they are providing. And through the MOPH regulations launched last year, now our KP-led providers can legally provide counseling, collect samples for HIV and STI testing, as well as to perform or to run the HIV and STI test within their CBO clinic settings, and then report the test results to their friends, along with giving out PrEP, PEP, and ART under supervision of healthcare professionals, which can be done remotely, as already demonstrated for the same-day PrEP service. And our engaged team at IHRI has led this effort to institutionalize the capacity building and certification processes for our KP-led providers. As you can see in this slide, the KP-led providers will need to be nominated by the CBOs. This is to ensure that once they complete the training and receive the certification, the CBO will endorse them to provide these clinical services within their own setting. And these KP-led providers will have to go through all the training processes and pass both theoretical and practical exams before they can get the certification. The Engage team has developed and tailored the training curricula and courses to the specific roles that each KP-led provider would like to take. And on the right side, the roles will be more advanced than the one on the left side, although we also want to make sure that even for a very basic and conventional roles of KP-led providers, such as to reach people, to recruit people into services, these roles are performed with high quality. But on the right side, you can see that the KP-led providers who completed this training and be certified will be able to provide HIV and STI testing, as well as to give out PrEP and PEP and ART under professional supervision. And as of now, over almost 2 years of intensive training activities, we now have more than 300 KP-led providers trained, with almost 100 of them already being certified. And you can see here that among those who are certified, many of them, the majority of them, are certified for advanced clinical roles, including testing and including prevention, meaning giving out PrEP and PEP. And in July this year, we held this national certification ceremony for those KP-led providers who were already certified. And in this ceremony, we have the UNAIDS country director, as well as representative from USAID, the Director General of the Department of Disease Control, representative from the MOPH, Office of Permanent Secretary, my father, as well as the Assistant Secretary General of NHSO. Again, he's the payer of the health system, health services in the country. And we hope that this national certification ceremony will help boost the visibility of the certified KP-led providers in our country, which will then help to enhance or to speed up the domestic financing mechanism from the pilot phase into the actual scale-up phase. And we also, again, over the past 2 years, have expanded KP-LHS technical assistance to our neighbors in Vietnam, Myanmar, Nepal, Indonesia, Sri Lanka, the Philippines, and Laos. And our technical assistance activities include the site assessment, the facilitation of community consultation in certain cities in those countries, and to the training for healthcare providers, not only KP-led providers, but also providers in the public health settings. And also we help set up the clinic and service package, as well as the data collection system, and then support the dry run of the service flow and provide continuous quality improvement and quality assurance. Currently, these activities are supported by AFAO through the SKPA program, as well as supported by FHI 360 through the EPIC program. Now with COVID-19, we can see that KPLHS has demonstrated huge potential for its adaptability in this emerging health crisis. We saw that our CBO colleagues and KP-led providers used all local adaptations in order to ensure that they can continue to provide these sexual health and HIV services to their clients, while the mainstream healthcare system were struggling to survive. We have seen that the telehealth, the express services where the clients can just come into the clinic to drop their samples, and then the test results will be delivered to them by online application or by email or SMS, as well as the self-sampling for STI testing, have proved to be quickly feasible and acceptable among the KP-led providers as well as their clients. And this is to ensure that sexual health will not be deprioritized during the time of COVID-19, and to also ensure that both the clients and the providers are safe receiving these services or providing these services during COVID-19. And outside of the clinical service aspect, our KP-led providers and CBOs also worked hard to ensure that the essential life needs of their friends are met. Swing, which is one of the key CBO colleagues that we have been working with, also created this life-saving guide and toolkit for sex workers who continue to provide service during COVID-19 in response to a plea for knowledge to protect themselves and protect their clients during this pandemic. Swing and other CBOs also worked closely with the provincial health offices to organize mobile clinics to provide HIV, STI, and COVID-19 screening and referral services, especially to sex workers whose health risks are enhanced during the COVID-19 pandemic. So to conclude, we can see that KPLHS is such a natural way to end AIDS. And with serious integration of KPLHS into the mainstream public health system, it will enable us to address any emerging health concerns now or in the future. However, the hierarchical and paternalistic health systems, which is very common in our region, can be main challenges, as well as the implicit stigma towards key populations, which remains common among healthcare professionals in our region. And lastly, I have to say that I really love South-to-South collaborations because they are always very friendly, very fruitful. And the South I'm talking about here is inclusive of Australia and New Zealand, not because you are geographically South, but because we know that you always treat your neighbors, your friends with respect and with equality. So let's do more and more South-to-South collaborations together. Thank you very much.
Thank you, Nittaya, for a fantastic presentation. It was very clear, succinct, and to the point, and I just really appreciate your out-of-the-box solutions to things. They're always ambitious and cutting edge and testing the envelope. So again, thank you for that presentation. We've got some time for a couple of questions, and Gillian Skinner and I were thinking along the same line. So I was wondering what are the aspects of a CBO that makes them likely to succeed, and then as part of that, you know, how long are the training courses and how involved are they for the members of these community organisations?
Mm-hmm. Yes, thank you very much, Tony. And I may want to address the second question first regarding the length of the training. And I have to emphasize that this is a serious capacity building. So the training courses, the length of the training courses varies according to the level of roles that you would like to provide. The one on the right side of the slide that I showed to you, which means that the lay providers who finish the training will be able to provide advanced clinical roles, including giving PrEP out or doing HIV testing or STI testing, can take up to 2 or 3 weeks, depending on the courses that is included into that particular curricula. And then that's only the theoretical training. We will also need these lay providers to then go back to their CBOs and practice under supervision of their senior colleagues or under the supervision of healthcare professionals within their same local This is to ensure that it's not only knowledge, but you also have the skills. We actually need more of people who have skills to provide the service. And that could take a few more months. For example, for PrEP, by being a lay provider, it means that you will need to demonstrate that you have this ability to initiate PrEP for 5 people, and then to do follow-up service for PrEP clients for another 5 people before you will be assessed and then certified to do these roles. And I have to say that it's not easy to identify CBOs who would want to go along this path in order to give or to perform non-conventional roles. Because there are still many CBOs to only just do the reach and recruiting roles. And as I mentioned earlier, if you are happy with doing business as usual, no one can do anything with you. But this is just an option, an alternative path that you can also explore. And I think that it is very, very important for us to make people realize that you have this potential to enhance your roles, and it's then your own decision whether or not you would like to follow this path.
Thank you. Rebecca Guy was wanting to know the types of point of care testings you were using, particularly with regards HIV and COVID-19 in the mobile service.
Okay, so at the CBO clinic, we have been using the 3rd generation rapid test kit for the HIV testing, as well as, but here it means that our CBO colleagues are not only doing the screening role, they are doing the screening and confirmatory role as well. So if the first test was reactive, then we have 2 confirmatory tests to confirm that you are really having HIV infection, so that we know which pathway, which actions we need to immediately take in for a certain client. And then we also use the Gene Expert for gonorrhea and chlamydia testing. The syphilis testing is also the rapid TPHA test. The COVID-19 is what the country has been using. So it's more of the antigen-based testing and not the antibody testing.
Thanks. So I think at this stage, there's more questions coming in, but I think at this stage, what I'd like to do is hand over to Ben Bavinton. So Ben Bavinton is a senior lecturer here at the Kirby. He's in the HIV epidemiology and prevention program and has worked in the field of HIV prevention for over 15 years, both in Australia and increasingly internationally. And his research focuses on the biomedical, behavioural and epidemiological aspects of HIV prevention, particularly in gay men and bisexual men in Australia and in the Asia Pacific region. Ben's worked with Nittaya before, and I'll hand over to Ben to drive the panel discussion. Over to you, Ben.
Good. Thank you very much, Tony. And hi, everybody. And thank you so much, Nittaya. That was such a pleasure to see that fantastic presentation. It's so exciting to see the innovation that you guys do in Thailand. It's just so impressive. So hi, everyone. As I said, as Tony just said, I'm Ben. I've had the great fortune of working with Nittaya before in the past on the Kirby Institute's Opposites Attract study, which was one of the 2 studies globally to prove that if a positive person is on HIV treatment, they can't transmit the virus to a negative partner in gay male serodiscordant couples. So there was previous heterosexual research, but our study was the one of 2 that showed that in gay men. And Nittya's team then at the Thai Red Cross was absolutely instrumental to the success of that study, because they really helped us recruit so many serodiscordant couples into the study and be able to have that really amazing finding that has gone on to support the U=U statement, consensus statement globally. So Nittya's also just done some really amazing work on U=U in the Thai context. And if we have time, maybe we can have a little bit of a chat about that, because although it's not directly related to today's presentation, it's really interesting. Yeah. And I know that a lot of you here at the Kirby have also worked with the Thai Red Cross and also the new institute that Nittaya heads up, and with Nittaya herself. So you might be familiar with some of her work. So what we're going to do now is just have probably about 10 to 15, maybe a little bit longer minutes of some kind of pre-prepared questions that I'm going to be posing to the panel that we have here today, which includes Nittaya, and then we'll go back to the questions that you've got on the Q&A site on Teams there. So I'll start by introducing our 2 panelists who will be joining myself and Nittaya. So first up, we have Matthew Vaughan. So Matthew is the Acting Director for HIV Sexual Health, and he's the Principal Campaign Planner at ACON, which is Australia's largest LGBT HIV community-based HIV prevention organisation, or HIV organisation. He leads the strategy and development of the multi-award-winning campaign Ending HIV, which seeks to end HIV transmissions in New South Wales. So he's worked in a range of different community, government and non-government roles, both here in Australia and internationally. And in particular, he's worked for several years at APCOM in Bangkok, which is Asia's peak community organisation for men who have sex with men. So we'll definitely be drawing on some of that experience in the next few minutes. And also, I'd like to introduce Dr. Horace Wong. So Horace is a clinician researcher with a background in nursing, public health, anthropology and health social sciences. So before completing his PhD at UNSW, which focused on the experiences of Chinese Australian gay men, he conducted social and epidemiological research on HIV among marginalised groups in Hong Kong and Australia. And he's currently working for a number of sexual health research projects for people from culturally and linguistically diverse backgrounds in Australia, as well as providing HIV and sexual health care as a frontline clinician. So thank you and welcome, Horace, as well.
Thank you.
All right, so I'm going to start with a question that I'll first direct to Nittaya and then maybe swing through to Matt and then to Horace about just a pretty open one about what is some of the main challenges for engaging key populations in your work? And you can choose which key population you particularly want to focus on in answering that question. So over to you first, Nittaya.
Yeah, that's a difficult question. I feel that since we started working with men who have sex with men population first, and then gradually towards transgender women, and now towards people who use drugs, I can see such a unique characteristics of each key populations, and I believe everyone would agree with that. We have faced challenges trying to get into the transgender women community at the very beginning, because none of us in the team are trans people. you know. So to break that wall into working with the community, I think we really, each of us may have our own technique or tips to share, but I think that's very important. If you really want to work, then you will need to be accepted by the community, right? It's true to people who use drugs, in which now I think it's more of the intersection in between populations. We will not be able to tell anymore that we are now working with MSM and not people who use drugs, because there are so many people who use drugs within the MSM or trans community, right? So I feel that every time we expand our work into new populations, we need to learn new things, and we need to really believe that we are so naive and ready to learn anything, learn any new things, and I think that's the key to the success. Yeah.
Great, thanks, Nittaya. So over to you, Matt.
Yeah, look, I think one of the challenges that we are constantly facing, or that I look at, is around getting message cut through, and for communities that we're working with to try and see the importance of what we're promoting or talking about. You know, we completely understand that life is busy, and you know, there's lots of things to do, or you know, moving through their different stages of life, but seeing that what we're talking about can actually improve that, or you know, getting them to understand that it's important, and competing with other challenges or things that they have going on at the time. I think that's something that we always look at, you know, on a small scale or a lower scale. That might be things like message cut through and advertising. How does something that we're talking about compete with brands like Coca-Cola or big, you know, other brands that, you know, have prominent displays or messaging, and so getting through that, you know, and then taking that to a more personal side of, you know, then, you know, not just the awareness, but the consideration and actual follow through, which is often a challenge of getting those later forms as well. So that's something that is certainly a big challenge for us.
Yeah, thanks, Matt. So Horace?
Yes, I totally agree with Nikita and also Matt said. I also think that like it is very hard to get to linguistic diverse populations. Like for me, I think as a Chinese speaker, I can get through to the Chinese speaking community quite easily. But for other linguistic diverse populations, especially for the Thai community in Australia, this is really hard for us to get through the message. Like as Matt said, get the message through them. And also there are a lot of new community happening, like people like community having chemsex, having like using drug online, then seeking sex partner online. It's a very difficult populations that we can get through, because they have like their own kind of culture and kind of own subculture or practice. And also transgender women as well. Asian transgender women in Australia, it's very difficult to for us to approach sometimes. I work in a clinic that we have like a transgender service as well. Sometimes we meet like transgender women from the Asian background. It's not easy to approach them or to maintain them in our service because of other like linguistic issue and also life issues nowadays, especially for the COVID-19. A lot of people like Mesa that really busy with their work and other things in their life. So this is another challenge that I think we should work on. Yep.
Yeah, great. So I might just stick on this theme just for a minute and go back to Nittaya to ask you a question about, I suppose you're probably aware that our situation here in New South Wales, but also more broadly in Australia, is there are now equal, if not more, HIV diagnoses in men having sex with men from overseas-born backgrounds than there are Australian-born. And a lot of the proportion of that is actually Asian-born men. And within that, there's a lot of Thai-born men and also Chinese-born men. So from your work with men having sex with men and transgender women in Thailand, do you have any advice for us on how we can better engage newly arrived Thai men who have sex with men and transgender women, particularly in getting them into that first reach, or the first one on your graphic saying getting them into testing? Because one of the big issues that we have here is with late diagnosis. They often don't get tested for quite a long time after they've been living here. And obviously that creates problems for their own health, but also for the transmission to potentially to other people. So we're really trying to focus on this issue of getting Thai MSM, but also other Asian-born MSM to test as soon as they arrive in Australia. So do you have any advice for us on that?
Yeah. That's a huge policy based question, right, Ben?
Yes.
But I think I mean I have seen your campaigns, no, printed in Thai and posted on the walls in the city. But you know, I mean, as a Thai, I would say that you still don't use Thai fonts. You know, it's not truly Thai font, so it's not really like relating to me.
Okay.
That's just probably one tiny thing that I can see. But I mean, the point is that if you really want people to get into the service, I think especially for those who were born outside of Australia and just moved into a new cities, new settings, new environments. Having someone who is really Thai be part of your team, I think that would help you a lot. I mean, I draw this experience from setting up the tangerine clinic for transgender women and transgender men, right? At the very beginning, we don't have enough trans staff on the team, and we just have a doctor who's an OB/GYN, a male doctor, and then a nurse who is very girly nurse. and we thought that, okay, we have good intention, good mind. That should be enough. But I don't think that will ever work if we don't have this full team of transgender staff at the Tangerine Clinic.
Yeah, great. Thanks for that. So Matt, I'll just direct one to you. So as mentioned earlier, you've worked at community organisations both in Australia and Thailand. And just for those of you who don't know, Matt actually directed a really large scale HIV testing campaign that was focused in Bangkok. And then eventually that actually moved to several other cities around Asia. So you've directed very large scale social marketing campaigns targeting MSM or gay men in both countries. So can you reflect on what you've learnt from developing and implementing campaigns in Thailand and perhaps other cities in Asia, and how these lessons might be applied to your current HIV education work with Asian-born MSM here in Australia?
Yeah. Look, I think one of the things that I really took back from my experience of being in Thailand and being in Asia was, you know, and you've seen it in Dr. Nitya's presentation today, the level of innovation that really comes out when, you know, you do have quite a large epidemic or, you know, among key populations, and the willingness to try things that are different and to look at things. And I think that's something that that I was able to tap into through working with partners like Dr. Nitya and some of the other community organizations in Bangkok, is by going, okay, this is something that we do really well in terms of engaging with communities. How do we then take that into the digital space, and how do we start creating this awareness and realization for, we're connecting with these people really well, but how do we extend the field further to extend that recruitment to people that we may not be always connecting? So whether that was through, you know, the developing engaging and humorous videos that were kind of not necessarily talking about testing at the beginning to capture that audience, but then got to the point later on, using innovative partnerships with people like Trasher that was responsible for doing these large scale dance parties because they had a massive connection with the same sort of target audience that we were trying to work through. Again, some of these things we already do here in Sydney, but it was doing it in a different space or a different environment or in a different level. And that's something that I certainly bring back with me now when I'm looking at ending HIV, is trying to keep that innovation up and enthusiasm and doing things differently. So, you know, there may be a way about doing a testing demonstration video, but how do we do it with that little bit of flair or pizzazz that makes it more inviting for people to watch? You know, I think something that remains a challenge, and certainly a lesson that I picked up in overseas, is, you know, the importance of just going beyond the superficial. So I think it's one thing, and that I've been really, or we've been working on internally at ACON, is it's more than just about putting a message out in language. And, you know, it's all very well and good to have advertising saying that, you know, in Thai language around testing welcome here, but being able to, have follow-up information that's available in language, being able to respond to questions that come up, being able to look at the service model that you're offering in terms of how accessible is that for people that are coming in, and how inviting is it for people that are using that space. And that's something that we're certainly perfecting along the line, and is going to remain a challenge as we continue to move into the future, but it's certainly extremely important. Yeah,
great. Thanks, Matt. And before getting back to Nittaya, because I'm sure you're waiting to hear more from her, I will just direct one question to Horace. So Nittaya's central idea in her presentation is that when the community has the tools, they can do what's needed to prevent HIV or to end AIDS. So how do you see this idea applying to Chinese MSM living in Australia? Are there specific barriers or facilitators that you've uncovered in your work that you might want to share?
Yes, sure. I think one of the things that really struck me from Nittaya's presentation is about the key population-led health service. I think one big problem of a health service in Australia that we provide to culturally and linguistically diverse population is that we always think from a health deficit model. We think that the culturally and linguistic people, they may be victim of kind of like health inequality, they're victim of racism, these kind of things. I'm not saying these things are wrong or are not they are not happening, but we could also think from a health access model approach, thinking like what the key population-led health service think about, like our Chinese community of culturally diverse community. We have the capacity, we have the knowledge, a lot of people, we have the passion to do much more for the community. But for whatever reasons, sometimes that kind of like opportunities were not there for the people to contribute to the community, or for a lot of like policies or other reasons or resources reasons, all those capacity that the community can't use the capacity to serve back to the community. So I think this is one of the best things that we've learned from today's presentations about how to utilize that kind of key population to serve the population. One very good example is the ACONS, I think with Sydney Sexual Health, the Chinese testing service. This is a very good example of doing that. And I hope that will expand the service a lot, and also to other service, other cultural group. This is what we want, because speaking back to your questions about the challenges of the Chinese community, because we also think about one thing is about the guanxi, the relationship in Chinese, we call it guanxi. It's not just like Matt said, we put the posters in Chinese, we have Chinese service here, we have like coming here, welcome, Chinese welcome here. It's not like that. It's more about how to get to the community, let the community members spread the words to other people, to let them know that this service is good. This is one of the challenges, because we always can't get through the community for whatever reasons, for the reasons that we have been talking about. So, yeah.
Yeah, that's a really interesting point, Horace, and I might flip this back to Nittaya then. In terms of your key population-led testing and other services, but also Tangerine, do you have a sense of how many people are coming to those services because of the peer word of mouth from their friends who've experienced the service, and how much is coming through your other routes, such as advertising on Facebook or anything else that you do?
Yeah, that's very important question, because then you will know how you would invest your resources in getting more people in coming to the clinic. So I have to say that like the Tangerine Clinic itself is probably quite a different model than compared to, like, let's say Swing or Rainbow Sky Association of Thailand, because Swing and Rainbow Sky may used to work in a way that they have their own outreach staff going out to certain spots or do online reaching or recruiting activities to bring people into the service. While for Tangerine Clinic, since we started as a clinic, as a very medical clinic, we don't have that staff doing the offline outreach to the population. So what we do is only to advertise through the online channel. And I feel that especially for transgender women community, you know already that there's this culture of mother-daughter sisters systems within the community, that once you are able to identify those sisters or mothers who already naturally act as an influencer for their communities, then we can invite those persons to be the spokesperson for the clinic. This could be done by like Facebook Live, having them coming in to talk to the providers in the clinic, or even to go through the services on Facebook Live so that people can actually see what is happening, how friendly it is, because we always say it's friendly, it's very trans specific, but if people don't see, then I think it's probably too challenging for them to get over that hurdle of visiting the clinic, right? Yes, and then after that, I think word of mouth came in, and this is true for Swing and for Rainbow Sky as well. I don't think that the majority of clients coming into Swing in Bangkok or Rainbow Sky in Bangkok are now coming because of the outreach activities. There's more word of mouth, so walk-in clients, and the walk-in clients now contributes to more than half of clients going to those CBOs at the moment.
Yeah, well, and you've raised something there that I think could be applicable to us here in Australia, particularly with our work in the Thai community here, but it may be applicable to other Asian cultures as well, where that idea of identifying those mothers and those aunties, that type of situation, because the same thing happens with the MSM community as well. You get these guys who are kind of influencers in a small way. So I'm not talking about the kind of Instagram way. I'm talking about the kind of, they've been here for longer, and all the new Thai guys that arrive get connected in with these people that they know who've lived in Sydney longer than them. And there's this whole network of kind of Thai transgender and MSM, and it's all quite networked together, support mechanisms. So, oh, I need a fridge. Where can I get that? I need a job. Can I work in this person's Thai restaurant? There's all this kind of connection there. And I wonder whether we could actually harness some of that for HIV prevention and testing purposes, which I don't think we've really particularly done yet, but I think it's a potential thing that we could do. I might just, did you want to say something, Nittaya?
Yeah, I just would like to endorse that recommendation because I mean, the influencers that we are talking about here is not someone who is celebrity. You know, yeah. They can be celebrities, but it's not always need to be someone who is a celebrity. And you may need like a pool of influencers because each influencers draw in different subpopulations within the larger population. So that's what I would like to add.
Yeah, definitely. So Matt, did you want to add something there?
Yeah, I just wanted, I mean, I think that influencers work in such a range of different capacities and have been for generations. It's just the internet has kind of moved that influencer marketing and kind of boosted it onto, you know, almost steroids to create net idols and whatnot. But, you know, there's that saying of keeping up with the Joneses. People often look to others around how they get influenced. That's how fashion works. That's how you take on new roles, that keeping up with the Joneses. That's why we feel, or particularly at ACON, why we use community members in our advertising as well, right, so that people actually, it's not about models or professional people all the time that's kind of like, yeah, they look amazing, but it's also about people saying or seeing these people look like me, or these people, you know, that person looks like me, or that person is the same as me. I want to tap into this, or I want to tap into that. And so, you know, using influencers, using influential people, but as Dr. Nittaya said, with each population, it's about almost admitting that you're a novice in this space again and going, what are the principles that, you know, for example, with ending HIV, we do a really good job at engaging Australian-born gay men and you know, ACON's very good at that. But now it's about going, okay, with this new, with new key populations, overseas born, Thai, Chinese, and other cultures, we have to look at that and go, okay, we're a novice in this space. Yes, some of us have a small amount of experience, but it's about going, okay, let's go back to the drawing board and go, how do we go back and do this again and look at some of those principles to apply that with our new target audience.
Yes.
Yeah.
Can I also add something?
Yeah.
There are three things I would like to respond to your comments. The first thing is that I totally agree with Matt that we have to utilize the online space in a more effective way, because like for migrants, referring to our discussion, for migrants coming to a new country, the first point of contact of searching for information must be the internet. Yeah, they search for internet to ask people questions, and then we have to think from the other way. Instead of posting all this information about testing, we may be thinking about what kind of information they need, rather than what kind of vision we need them to know. Probably they want to know about how to get more information about finding a job. Then how can we use that kind of message, and then we incorporate our message of HIV testing on that to them. Another thing about influence I want to say is about the PrEP in the city campaign. I remember in the presentation talk about how to show like transgender people use PrEP in their daily life. So the influencers should be very relatable, not talking about like beautiful people that they've reached, they have good body, showing off their body. Just how migrant can use PrEP, incorporate PrEP to their daily life or busy lives. That's another good way that we could think about it. Another thing I would like to add on that is referring to Ben's mother and sister network. So this is what I've been thinking about, the network or the resources that migrant community actually they have. But we haven't been using this network or the resources they already have to utilize these resources to help promoting our messages. So these are probably the things that we could work on in the future. Yeah.
Yeah, great. So just for the next few minutes, I'm going to jump back to the audience questions, and obviously most of these are directed directly at Nittaya. But Horace and Matt, if you want to jump in at any point, just send it on the chat and I can send it over to you. So the most upvoted question that we have is one that's from Justin, who's saying that he loves to see these PrEP ads in the BTS stations and it's so positive. And he knows that Thailand has a very accepting attitude towards the trans community overall, well, at least comparatively to many other places. But he's wondering if there's been any pushback from the mainstream public health system or from the general public since last Wednesday you put out the campaign.
Yeah, that's a great question. And I mean, although I have been showing like the success steps of the activities that we have been doing, it doesn't mean that it's success since the beginning of these activities. And the PrEP in the City campaign also shared those challenges. And it's even at the stage of we inviting those transgender women who will portray this daily life with PrEP that we struggled with a few managers of these transgender women who would not want the look of these people to be linked to HIV or to be linked to PrEP or to be linked to being transgender women, you know. So that's one stage. But we finally, because I think because the production of this campaign is done by transgender team themselves, that they have the way to talk around and then get to the point. And then we then faced the big challenge in how we launched the campaign. You know, I showed to you the large LED screen at the Asok intersection, but actually we have a better spot of LED at Paragon. Right now, so if any of you who have been living or traveling to Thailand, you will know that's the best spot. And that's part of the package that we would have this campaign projected on the LED screen. But just a few days before the launch, we got the message that it's probably not a good idea to have this campaign shown in the Siam Square area and Paragon area because there are too many students around. We actually don't know if it's because when you say that it means that you link PrEP to something that is not good for children, for kids, for young population, or it's anything related to transgender women. We don't know. We actually don't have like a documented response from the team, and we are still working with Paragon to see if we can finally get their okay to do this on their screen. So that's another thing. So far, because I think we have been projecting this campaign in a gain framing way, we have not yet received any direct negative responses from the public community in terms of like you are telling people to not using condoms or anything like that. So I think it's our intention. We just need people to see PrEP and then explore further, and if that fits their own life, own needs, then we are ready to tell you more.
Yeah, fantastic. So I've got a few questions here that are on a similar theme, which I think is about expanding the key population-led health service model to the other countries. So you mentioned that you've been working with various places. So one from John Caldor was saying, can you comment on the ways in which the model has been adapted to other places, to local community needs and priorities? One from Mahendra who said that it's being implemented in, you mentioned Indonesia there, but could you comment on what form it's being implemented, because it's culturally different from Thailand? And we had a couple of comments further back here from Greg Gray from Afeo, Bangkok, saying that if we can scale up and encourage other countries in the region to use this model, he believes that will be successful. And obviously you do too, because you're doing that work. But it does require ownership and leadership from the government and ministries of health. And it also requires support and financial investment in CBOs, which I know has been an issue in Thailand for a long time as well, but maybe a bigger issue elsewhere. So just based on those three people's comments, would you like to just talk about how you've implemented in other places, and this idea brought up by Greg about the sort of challenges from the ministry and funding perspectives?
Yeah, these are all great questions, and I have to say that we don't have any predefined model of how KPLHS should be expanded in this country, that country. Same thing to when we expand this to different provinces in the country. We are not like going in and say that this is good thing, please do this, and we are going to set this up for you, etc., etc. I don't think that will work anywhere. Yeah. I feel that the most essential step is the starting step, where you really would want to show that this is like it's truly South to South collaboration. We are not coming in as a North to South collaboration where we know that you need help and we are going to help you. It's not that way, and that we will also encourage each city, each country to listen to what the communities really want, because even though Tangerine Clinic model has been working very well in Bangkok, it does not mean that it will work well even in Sydney, and you will need to listen to your own transgender community in that setting. And then the service package could be different. It may not be the reach, recruit, test, treat retain cascade that we are familiar with in Thailand, but it could be like you may have different entry point than let's say HIV testing for transgender community, because they are more concerned about their gender affirming care, for example. Yeah. So I think that's the essence of how key population-led health service will work. The reality, though, when we have to implement these activities under different funding sources may not allow us to do so, to do what I just described to you, because it takes time, right? It takes time really to try to identify who are stakeholders in that certain settings, and then to be calm enough to listen to everyone, and then set up what is best for everyone, and then aim at achieving that goal together. Because grants, funds always have their timeline, right? That you have to do this by this month, you have to do this site visit, and then the service needs to start in the next 3 months, which may not allow us to do so. And at the same time, having a funding source where you already have predefined set of stakeholders may also act as a barrier in doing so. Like if this is U.S. government money, these are stakeholders you need to work with. So I mean, I'm telling you more challenges than what we can do. But I think that's the concern. That's the point that we should consider in expanding any models into other countries. What we can do is that, I mean, as an implementer, I think everyone here in the audience is, as an implementer, you may need to balance this as best as you can. Talk to your funder, talk to the local implementers in the country, and be the facilitator. I'm not saying that we have to always believe our funders of what we should do, who we should work with, and as much neutral as you can stay in the eyes of stakeholders in that certain setting. I think that's the more benefit it will happen in that certain setting.
Yeah, thanks for that, Nittaya. That's really important, I think. And I think it's one of the reasons why personally, I'm so excited to see the Thai Red Cross and now IHRI really develop and have grown so strong, is that you're able to give this direct technical assistance in this very much more partnership and collaborative model, rather than this very, very top-down donor-led model, which when I was living in Thailand, it was all about the donor-led model, and most of the programs failed because they weren't paying enough attention to what was actually on the ground and what the local needs. So I just got a technical question, or yeah, pretty specific question for you, Nittaya, and then I'll move to one that is one that everybody can comment on. So Jesse has asked, can you please comment on whether lay providers are allowed to perform blood draws and other sample collection at these sites? And were there challenges within Thailand's regulations regarding that?
Excellent questions, and that took us years to overcome this obstacle, because in Thailand you have 3 main professional institutions: the Medical Association of Thailand, doctors, and then the pharmacists. You have Thai Pharmacist Association, and then you have Thai Medical Technologists Association, so the lab people. According to the regulations of these professional institutions, only medical technologists can draw blood. Yep. Not even nurse. We also have the Nursing Association. Nurse cannot draw blood. While throughout these 1,000 hospitals in Thailand, nurse is the one who is drawing blood every day, every morning. We don't have medical technologists going to inpatient wards and draw blood at 4 a.m. or 5 a.m. right? And it's always there. So it's like this gray area of medical practice already in the country that when we try to say that, okay, now we have another new comer, and these people is called KP lab providers, and we also would like to draw blood and do testing. Certainly this caused like a panic to every professional associations. And so we took time. We have national consultations. We have like personal meetings, talking, bringing high level people from these associations to visit the CBO clinics to demonstrate that this is practice that is done according to the guideline, the standards, right? It's not just anyone who call themselves lay providers can just draw blood. So finally, we got to the point that we have these MOPH regulations announced specifically for KP lay providers, and giving the justification that because Thailand aims to end AIDS in the next 10 years, that we need these roles from KP lab providers. And what KP lab providers will do is just to do sample collection for HIV and STI testing. And we are saying this in a way that I'm not saying that it would be only blood collection. We may want to also collect oropharyngeal samples and anal samples and urine as well for STI, right? And this is and what is mentioned in this regulation is that, and the testing will be done using the point of care laboratory assays. So that means that, okay, it's not like we are going to set up a large laboratory in the CBO clinics, but any point of care systems that can test for HIV, gonorrhea, syphilis, chlamydia, then these samples collected will be able to be tested by these KP lab providers. So it's more of the language thing, but I think it make these professionals feel comfortable enough to allow these regulations to be passed and endorsed after it was announced 3 months, because you can appeal this within 90 days, right? And we were so like wanting the 90 days to pass quickly at that time. Yeah.
Okay, thanks for that. So look, in the last sort of 2 to 3 minutes, I've kind of left the most difficult question from the audience to last, which is probably not the best thing. So someone has raised here the challenge of stigma, and obviously we can't have this conversation without recognizing stigma. Stigma for our populations in various ways. There's HIV stigma in all of our countries, but it's so intense in Asia, in particular countries in Asia. But also MSM stigma, transphobia, stigma towards trans people, stigma towards all these key populations. So reaching these key populations still is a challenge everywhere, this person points out, and these subpopulations are highly stigmatized, and it's not easy. So I guess I might throw to Horace, then Matt, and then Nittaya, you can have the last word, just to say anything you would like in response to this comment about the reality of stigma that we face here and across Asia. Horace?
Yes, I think stigma is a very big thing that, as you said, like not only for Asian men in Australia, not only a stigma for being gay, but also for stigma for being like a migrant or being like a cultural diverse background. So there's intersectionality in between that. One thing to tackle stigma, I think it's not only working on the community side, we have to working on the general population side. So no matter what we do about the community, the gay men, we are tackling stigma. But what if the public, general public thinking about the opposite? That's not working at all. So I think we have to do more public education and campaigns to entail stigma rather than just focusing on certain population. Yeah, and of course there are like stigma against like gay men against transgender people, like white gay men against, like there are lots of intersectionality, identity covering, overlapping. So it's a huge difficult work, as you said. Yeah, hey, Matt, what do you want to say? Yeah.
Yeah, look, I absolutely agree with what you said, Horace, and that certainly the intersectionality and the overlapping that compiles with stigma. Yeah. I think something that we have done really well in Australia is we've had a lot of really strong HIV activists that have come, yes, you know, certainly much longer or much before many of us here on the panel. And, you know, they've been very open both about their sexuality, their HIV status, and the intersectionality that plays. And, you know, I really want to pay tribute to those people. Yes. And also acknowledge that, you know, stigma still happens here, absolutely. But I am aware that particularly in Thailand, where stigma, or a lot of Southeast Asian countries where there is that overwhelming sense of stigma, they also haven't had that space for a lot of advocates to kind of come through. And I really don't think that you can undervalue the role that plays, that community advocates and that leaders that are prepared to be open about their sexuality, about their HIV status, in terms of coming forward, and how that plays to unpack stigma out in a country. And it is always hardest for the first generation of people, but we know that one of the biggest things that can break down stigma for people is them meeting somebody and putting a face to face and having that experience. And so, you know, if there was something that I was thinking about what would be important to kind of translate over, it's really that advocate space and, you know, people that are prepared to put themselves forward, realizing that it's a big ask in the first instance or for that first generation, and best of luck.
Yeah, and perhaps thinking about the ways that institutions such as Nittaya's and ours can support those individuals.
Definitely.
Make sure they're not just left out to kind of suffer the way that a lot of people 40 years ago in Western countries were, because those institutions didn't exist back then. So Nittaya, I'll hand over to you if you want to make a comment on stigma just for the last few minutes.
I feel that the explicit stigma right now towards HIV and all other related stigma to HIV, whether that be the populations, the behaviors, the settings, has become more delicate. No? Sometimes you don't feel that it's stigma, but it's explicit. It's still explicit stigma that you are doing. You are experiencing. So for me, I think that it's probably like we could not assume that people understand what stigma and what the discrimination is. And so education is still, and public education, as Horace just mentioned, is something that we need to invest in more. We may have done work more in the healthcare settings towards reducing stigma discrimination toward people living with HIV. But I think that's just a tiny part of the overall stigma in the society. And I believe that influencer works for getting people into clinical services for HIV should also work well to address stigma discrimination in the country as well, because we have seen that a negative influencer really did a good job in expanding, enhancing stigma discrimination in the society, because he or she is an influencer. So why not do the same thing, but in a positive way?
So I think, Tony, it's back to you.
Thanks, Pen. So I wanted to thank everybody in the audience who provided such insightful questions that helped drive that very dynamic discussion. I'd really like to thank our panel members, Horace, Matthew, led by Ben, for an insightful and dynamic discussion. But most of all, I'd like to thank the technical team behind this, Elaine and Estelle and Lucy, who pulled this together. And I think it's from here, it's run without a hitch, which is extraordinary. And we've got a forum where we've actually had quite dynamic discussions. And I think that's been really driven by the absolutely excellent presentation that Nittaya made, which was really was presented with absolute clarity and insight. And that insight was full of thoughtful knowledge that was hard-won and derived from hands-on experience. So I think it was really very much the complete package, and a great honour to Brett Tindall. who I think would endorse everything that's been said here today. So I'll close there, just thanking everybody that participated. Thanks very much.